Hi, everyone. Thank you so much all for being here today. My project addresses a question with major real world implications. How should post op rehab actually be delivered in health systems where access isn't equal? We know that multiple models work clinically, but delivering rehab in a way that is accessible, consistent, and equitable, especially in geographically dispersed provinces like Newfoundland and Labrador, is where the system often breaks down. So, before I begin, I'd like to respectfully acknowledge the territory in which we gather as the ancestral homelands of the Beothuk and the island of Newfoundland as the ancestral homelands of the Mi'kmaq and Beothuk. So, a bit of an overview. I'll begin with my practicum context and the public health challenge of rehab access in Canada. I'll compare clinic based and home based models using also the REAIM framework, and close with some key findings, policy implications, and a proposed future direction. So during my practicum at the Health Science Center in St. Clair's in Newfoundland, one of the biggest gaps I identified was inconsistent and inaccessible post-op guidance. Patients are expected to recover at home, but are often sent home with fragmented instructions with no clear sense of what to do or when to seek help. So in response, I developed 12 standardized patient-friendly rehab handouts, translating complex clinical protocols into clear, actionable recovery pathways, built on current evidence and refined with the input from surgeons and physiotherapists. In terms of the methods and approach, my approach combined a structured literature review of randomized controlled trials, systematic reviews, and meta-analyses with a systems-level evaluation using the REAIM framework, and a knowledge translation component through the patient handouts. And the goal here was not just to compare models between clinic and home base, but to understand where rehab breaks down in practice. I specifically chose this REAIM framework because it moves beyond asking, does this work, to asking, does it work for everyone in every setting? Which is exactly the right question when you're dealing with a geographically dispersed region like Newfoundland and many areas in Canada. One of the most meaningful parts of my practicum was developing these post-op rehab handouts, which is shown here on the right. These handouts are more than educational tools, they're a standardization strategy. So for me, rather than starting from scratch, I reviewed the existing material that we had at the Health Science Center and integrated up-to-date evidence and refined them with direct input from the orthopedic team. Each handout includes plain language instructions, illustrated exercises as shown on the right, week by week recovery timelines, so they have smaller bite-sized goals and realistic expectations of where they should be, and clear guidance on warning signs and when to seek help. So this level of structured, consistent information is currently missing for many patients, and that gap drives unnecessary uncertainty and avoidable follow-up. For example, like a patient who doesn't know that swelling at 6 weeks is normal might drive 3 hours just to be told exactly that. So these handouts kind of aim to prevent that by giving patients the confidence to know what's expected and the clarity to know when something is wrong. An interesting stat. According to the Canadian Institute for Health Information's 2026 report, over 175,000 hip and knee replacements are performed annually in Canada, a 26% increase since pre-pandemic levels, costing over $1.4 billion in hospital costs alone, making the optimization of recovery and rehab outcomes more critical than ever. So with orthopedic procedures rising alongside an aging population, post-op rehab is just as critical as the surgery itself. Yet, access remains unequal. In Newfoundland and Labrador, patients are often traveling hours for follow-up care that could be managed closer to home, highlighting a challenge that is not clinical but geographic, financial, and systematic. Rehab has traditionally relied on clinic-based care, but home-based models supported by telehealth offers a more accessible and lower-cost alternative. The evidence does support both. The real challenge is implementing them in a way that reduces health inequities rather than reinforces them. Clinic-based care, as you imagine, offers that direct supervision and early monitoring. But for a patient 4 hours from St. John's, that model creates immediate barriers. Home-based care solves the access problem, but introduces a new one. Patients need structure and clear guidance to succeed independently. So here's the REAIM framework: reach, effectiveness, adoption, implementation, and maintenance, to evaluate these two different models and how they perform in the real world, not just in theory. Both are clinically effective according to the literature, but break down in different in practice. So clinic-based is constrained by geography and access, while home-based care depends on patient structure and support. And what REAIM makes clear is that the core challenge isn't the evidence, it's the implementation. The literature consistently shows both models produce similar long-term outcomes in terms of pain, mobility, functional recovery. But I'm reiterating, the real difference lies in access cost and system efficiency. So some interesting things that I found in the literature were that about 21% of Canadians live in rural areas, let only 3% of physiotherapists practice there. And for every additional 10 minutes of travel, that increases missed follow-up risk by 3%. Home-based rehab can be 5 to 26 times less expensive, but without the structured guidance, non-adherence reaches 70%. When the program incorporates structured protocols and telehealth monitoring, adherence can exceed 90%. So this gap is exactly what this project aims to address. Health equity was a central theme of this project. Access to rehab is shaped by geography, income, health literacy, digital access, and in rural settings, these barriers are all compounded. Even when two models are clinically equivalent, they are not experienced equally, and rehab isn't just a clinical service, it is a public health issue. So in terms of policy recommendations, we know both models work, but home-based rehab fails without these standardized protocols and proper patient guidance. So moving forward, I think it's really important that we have that investment in rehabilitation infrastructure, the standardized home-based protocols, hopefully provincially and nationally, and public funding reform for outpatient physiotherapy, especially for those rural patients or any patients without a viable alternative. In terms of strengths of this project, it is grounded in randomized control trials, systematic reviews, and meta-analysis, strengthened by real-world clinical context and the REAIM framework to evaluate beyond just clinical outcomes. The main limitations, however, are the absence of primary data collection, limited Indigenous-specific rehab evidence, and the variability in how home-based programs are designed across studies, which are all areas that warrant for future research. This project strengthened my ability to evaluate health systems through an equity lens and translate evidence into practical tools. It reinforced that improving outcomes isn't just about evidence, it's about how that evidence reaches patients in real-world settings. And as a future physician, I hope to design care that is not only clinically effective, but more importantly, accessible and responsive to patients' real-world contexts. This practicum gave me a different lens on what good care actually looks like. It's not enough to perform a technically excellent surgery. If the patient goes home without understanding their recovery, we've only really done half the job there. So key takeaways, both models are clinically effective. So the problem isn't the evidence, it's implementation and equity. Home-based rehab fails without structured protocols, and clinic-based care fails rural patients without accessible alternatives. And until funding and infrastructure catches up, this gap between what works in research and what happens in practice will persist. And I'm excited to share that building off this master's work, I will continue a next step with a prospective mixed methods cohort study testing whether the standardized digital recovery platform where we give patients plain language handouts, illustrated exercises, videos, frequently asked questions can reduce unnecessary follow-up burden across our orthopedic trauma team. Many visits aren't driven by clinical need, but by patient uncertainty and poor access to clear instructions. And current materials are often written above patient reading level. So, by comparing the digital pathway against usual care, we'll measure whether better information improves patient confidence, reduces unscheduled calls and visits, decreases travel burden, which are all outcomes that matter clinically, financially, and especially here in Newfoundland. Ultimately, this study asks a very simple question, but important. Can better information replace unnecessary visits? And if yes, the implications for rural access, system, and efficiency and patient experience are significant. I'd like to thank my practicum supervisor, Dr. Helena Green. This would not have been possible without you. My master supervisor in Victoria, Dr. DeBar, and the orthopedics team here in Newfoundland for their mentorship and support. Thank you guys all for being here and for listening, and I'm happy to take any questions.